Let's warm up for Endocrine 9. First question, a tall, thin male teenager has abrupt onset dyspnea and left-sided chest pain. Percussion on the affected side reveals hyperresonance and breath sounds are diminished. So what's the diagnosis? Well, this is a classic presentation of a spontaneous pneumothorax, not a tension pneumothorax, just a simple pneumothorax. And the last question, in a population of 100 workers that worked to clean an oil spill on a beach, 10 developed leukemia. In a population of 1,000 hotel beach umbrella monitors on a clean beach, 50 developed leukemia. So what's the attributable risk? So here's how you set up the problem. What's being evaluated here is the potential risk of developing leukemia, and then the risk factor is an oil spill cleanup. So the question stem tells you that 10 out of 100 people exposed to cleaning up oil develop leukemia. So your A is 10 and your B is 100 minus 10, which is 90. In the unexposed population, 50 out of 1,000 people develop leukemia. So your C is 50 and your D is 1,000 minus 50, or 950. Then it's just a matter of plugging the numbers into the formula for attributable risk, which is A over A plus B minus C over C plus D. So you plug in those numbers and you get an attributable risk of 0.05. In other words, even though 10% of the oil spill cleanup group got leukemia, only 5% or half of that is actually attributable to the participating in the cleanup, because the other 5% were going to get leukemia anyway based on the data from the beach umbrella monitors. So that's it for the warm-up. Now let's move on to the lecture.
So welcome to our video on thyroid nodules and thyroid cancer. Lots of people have thyroid nodules. You're going to see a lot of these in clinical medicine. Most of them turn out to be benign adenomas. And these nodules can be isolated or multiple, and a thyroid that's enlarged or has multiple nodules is sometimes called a goiter, which is a word you heard in the last couple of lectures with respect to disorders of thyroid function. So as it turns out, nodules and goiters can be associated with normal thyroid function or hyper or hypothyroidism, as we talked about. It's important to know that the structural and functional thyroid problems are not always related, despite the buzzwords we discussed in the last two lectures, which you shouldn't forget. So in this lecture, we're going to mostly forget about thyroid function and hormone levels and focus on structural issues. So as is the case with any kind of mass, the most important thing is first to identify it and then to characterize it with imaging. So with thyroid nodules, this is done best with ultrasound, which is a nice, cheap, low-risk test. So you can see several things on the ultrasound: size and location of nodules, the background thyroid tissue, and there may be patterns consistent with Hashimoto's, etc., which you may already know clinically in some cases. Then you can also look for abnormal lymph nodes in the neck. However, there's one very important question that you can't answer reliably with ultrasound, and that is whether the nodule is benign or malignant. So you have to treat most individual nodules as if they could be malignant, even in the context of a multinodular goiter. So the only way to make a definitive distinction between benign and malignant nodules is pathology, which has to be obtained with a biopsy. As is the case in most cancer diagnostic tests, tissue is the issue and cancer is the answer. So for the thyroid, we do fine needle aspiration, FNA. We use a fine needle because the thyroid is very vascular, and bigger needles cause a lot of bleeding, which can make interpretation more difficult for the pathologist. Now, you may remember talking about thyroid uptake and scan tests from the lecture on hyperthyroidism. And we don't really order uptake and scan tests routinely to assess thyroid nodules, since most nodules, benign or malignant, are cold on these scans. However, if you happen to have the data from an uptake and scan in a patient with hyperthyroidism maybe, and a nodule is hot or lights up, that ends the evaluation, because thyroid cancers really are never hot. They aren't making thyroid hormone like normal thyroid tissue would, and they certainly aren't overproducing. So the rest of the discussion here is heavy on the pathology, the cellular and microscopic features of these tumors, because that's how we differentiate the types of thyroid cancer. So the most common type of thyroid cancer is papillary, named for its particular pathologic appearance on histology. Papillary-shaped cell groups without the usual thyroid follicles or colloid. We don't get a nice histology from FNA, just cells, so there are cellular features to look for as well. So under the microscope, you'll see a ground glass appearance of the cytoplasm with large nuclei with nuclear grooves or little inclusions that look like holes. The nuclei can also look clear, and this is the finding pathologists refer to as the orphan Annie eye nucleus, which you can see here. Now, if you don't know who little orphan Annie is, here she is with her white eyes, and maybe that helps you to get the image of little orphan Annie's eyes so that when you see the pathology, you can see those nuclei with a clear appearance. And you might also see psammoma bodies. Psammoma bodies have concentric calcifications, which can look like a loose spiral or like a chunk with tight layers in it. A student sent in a comment one year that we liked. Samos, like in psammoma bodies, comes from the Greek word meaning sand. And Annie's dog in the story was named Sandy. So you can remember that orphan Annie eyes and psammoma bodies are related in the context of papillary thyroid cancer, which you'll just have to memorize. Risk factors for papillary cancer are tobacco use and exposure to radiation, usually some kind of treatment dose radiation and not just x-rays. Papillary cancer also can be hereditary, and in these cases often is associated with the RET gene mutation or a mutation in the BRAF gene. Activation of receptor tyrosine kinases is seen in both papillary and medullary carcinoma. Fortunately, papillary thyroid cancer has a good prognosis and rarely is life-threatening, although it does sometimes recur. There's a 3-to-1 female predominance, and it commonly occurs in the 3rd to 5th decade of life. Treatment of papillary thyroid cancer is to remove the entire thyroid, and in many cases follow this with a radioactive iodine treatment. So this is similar to the iodine treatment we use for hyperthyroidism, except the dose is much larger. That's because in hyperthyroidism, the cells are really avid for iodine because they're pumping out thyroid hormone. This is not so with cancerous cells or with normal thyroid tissue, which use iodine a little more slowly. However, it does still help prevent recurrences in some cases. Conceptually, I like to compare it to cleaning up with a vacuum cleaner after you've already swept with the broom. That's the surgery. So let's move on to follicular thyroid cancer. This is the second most common thyroid cancer and has a slightly worse prognosis than papillary carcinoma, although it's still generally good. So under the microscope here, we see uniform cuboidal cells lining follicles. So follicular carcinoma is a cancer of follicle cells that are then surrounded by a fibrous capsule. And as it turns out, this is also the appearance of a benign follicular adenoma, which is one kind of benign thyroid nodule. So the difference with this carcinoma is that it's invasive. Particularly, you can see the cells invading the fibrous capsule. And furthermore, follicular carcinoma can spread hematogenously, which is unlike papillary thyroid cancer. Most carcinomas spread to lymph nodes in the neck, and follicular carcinoma can do this too, but the hematogenic spread can be a big problem. So commonly, follicular carcinoma is associated with either a RAS mutation or a PAX8 PPAR gamma 1 rearrangement. And again, with follicular carcinoma, we see a 3-to-1 female predominance. And again, the treatment here is total thyroidectomy, followed in some cases by radioactive iodine. Now I'd like to make a quick comment here about follicular adenomas, which I just mentioned a second ago. So here we again see a proliferation of the follicles surrounded by a fibrous capsule, but in the adenoma, unlike follicular carcinoma, the follicle cells do not invade the fibrous capsule. So the other thing is that sometimes these adenomas can secrete thyroid hormones and can actually be an important cause of hyperthyroidism if they stop responding to feedback. So it's important to know about follicular carcinoma and adenomas because with an FNA sample, the pathologist can't see the fibrous capsule. The architecture of the tissue isn't represented after it comes up the bore of a needle. So in the past, we used to get really annoyed when we saw follicular lesion on the path report from a nodule FNA because this meant we didn't have an answer for the patient. We'd have to remove any follicular nodules to make sure they weren't carcinomas, and about 20% of them are, so that's not trivial. And sometimes we still recommend this. However, now there are gene expression tests done by specialty laboratories with the FNA sample that can help make the distinction. So we're able to avoid some unnecessary surgeries this way. So let's talk now about medullary thyroid cancer. This is a really unusual kind of cancer that occurs in the thyroid but doesn't involve the thyroid hormone producing cells. It actually is a proliferation of parafollicular C cells which form the medullary part of thyroid tissue. And these cells secrete calcitonin. Let me say that again because it's pretty high yield to remember. Medullary thyroid cancer equals high calcitonin. Medullary thyroid cancer is associated with multiple endocrine neoplasia syndromes, MEN2A and MEN2B. And this is important because patients found to have medullary thyroid cancer must be screened for pheochromocytoma before surgery to remove the thyroid. And you also should know that medullary carcinoma is associated with the RET gene mutation, just like papillary carcinoma, and activation of receptor tyrosine kinase is seen in both papillary and medullary carcinoma. So a quick word on treatment of medullary carcinoma. All thyroid cancers are treated with total thyroidectomy, as I've said. But in papillary and follicular cancers, we also use radioactive iodine to ablate any surgical remnants. However, medullary cancer doesn't respond well to radioactive iodine treatment because it isn't a carcinoma of actual thyroid hormone producing cells. It's in the medullary part. So with this, it's surgery and hope for the best. Okay, so now we're going to move on to the last kind of thyroid cancer we're going to discuss, which is anaplastic thyroid cancer. As the name implies, this is an anaplastic, undifferentiated neoplasm. This is more common in older patients, although fortunately pretty uncommon. So remember how we talked about Riedel's thyroiditis being a rock-hard thyroid with possible local extensions? Well, if you see that scenario in an older patient, then you should think anaplastic thyroid cancer first. In a young patient, think about Riedel's thyroiditis. And unfortunately, this anaplastic cancer is rapidly fatal. Then let me remind you that other types of cancer can be seen in the thyroid gland. Metastatic disease can appear there, which of course would be picked up on an FNA sample. You can also see B-cell lymphoma in the thyroid, which I mentioned in the hypothyroidism lecture. This is associated with which common cause of hypothyroidism? Hashimoto's disease. So before we wrap up the section on thyroid nodules and cancer, I should mention that even benign adenomas and multinodular goiters require some surveillance. Sometimes these can grow quickly or to pretty large sizes. And you've probably seen pictures of people with giant growths coming out of the side of their necks. But anyway, benign goiters don't invade in the same way that malignancies will, but they can still squish things in the neck, important structures like the esophagus or even the trachea in severe cases. And these goiters need to be surgically removed to prevent complications from compression. One last thing I'll mention about the thyroid is about surgical complications of thyroidectomy. So of course there's always general surgical risk, but there are a couple of things specific to thyroid removal, and this is high yield. So first, you could remove or damage the parathyroid glands, which are stuck to the back of the thyroid. Sometimes they can even be inside the thyroid, and removal of all the parathyroid glands would cause hypocalcemia, which would manifest with perioral tingling, myalgia, or cramping, potentially followed by really bad things like tetany or seizures in the early post-op period. And there can be transient hypocalcemia from stunned glands that can then recover over some weeks as things heal. And the second complication is there can be damage to one or both recurrent laryngeal nerves. So that's a branch of the vagus nerve that innervates the thyroid and the vocal cords. So if you damage it, then the result is hoarseness. So here you can see the posterior view of the pharynx, and you can see how the recurrent laryngeal nerve runs by the thyroid and could easily be damaged in a thyroidectomy. All right, time for the end of session quiz. Pause the video and go through the questions, and then we'll go through the answers together. So what type of cancer in the thyroid is associated with each of the following statements? Activation of receptor tyrosine kinases is seen in both papillary and medullary carcinoma. Hashimoto's thyroiditis is a risk factor. This is B-cell lymphoma. Cancer arising from parafollicular C cells is medullary carcinoma. Commonly associated with either a RAS mutation or a PAX8 PPAR-gamma1 rearrangement. This is follicular carcinoma. Commonly associated with rearrangements in the RET oncogene, can be either papillary or medullary carcinomas. A mutation in the BRAF gene is seen in papillary thyroid carcinoma. Next question, what nerve can be easily damaged in thyroid surgery and lead to hoarseness? That's the recurrent laryngeal nerve. All right, that's the end of session quiz. Let's go through some rapid fire facts. Most common thyroid cancer, papillary thyroid carcinoma. Enlarged thyroid cells with clear ground glass nuclei, papillary cancer of the thyroid. That's the orphan Annie I nucleus. Most likely electrolyte abnormality with perioral tingling, perioral paresthesias, and recent thyroidectomy. That's hypocalcemia. And that's the end of our video on thyroid cancer. See you next time.